CPR from the Department of Pediatrics. So from Unit 3, from the Division of Pediatric Oncology, I invite Dr. Jagdish to introduce the topic and the speakers.
Good afternoon, everyone. So on behalf of Unit 3 Pediatrics, I welcome all of you for this CCR. The title for this CCR is Fighting a Double Better, Malignancy and Invasive Fungal Infections. Here we will be presenting 3 cases of infections which are not uncommon in immunocompromised patients, with highlighting atypical presentation and complex therapeutic challenges. The JR from Pediatrics will present the cases, while senior resident for pathology, pediatric surgery, and radiology will describe the key finding. Subsequently, senior resident for pediatric oncology will discuss the review of literature. Now I invite Dr. Suresh, JR Pediatrics, to present the cases.
Good afternoon all. Let's begin with our cases. So the first case, Miss I, a 3-year-old girl, a case of the acute lymphoblastic leukemia, was stratified into high-risk group, being a BCR A-grade translocation positive, was started on induction chemotherapy on 21st June 2024, and she was also started on imatinib given that she was positive for Philadelphia chromosome. Post 3 weeks of induction chemotherapy, she presented to the casualty with complaints of obstipation for 3 days along with progressive abdominal distension. She had history of bilious vomiting for a day and history of low-grade fever spikes. Initial possibilities were acute intestinal obstruction. Given that she was on induction chemotherapy, which was vincristine induced IES was also considered. And it is a common thing that the children of malignancy on induction chemotherapy tend to develop neutropenia, subsequently enterocolitis. However, an odd point was that child did not have loose stools at presentation, and subsequently on evaluation there was no neutropenia. But still upfront we had considered neutropenic enterocolitis. On further examination, the child was hemodynamically stable apart from the tachycardia which was attributed to fever. She was anthropometrically preserved. And on examination had tenderness, guarding, and on auscultation the bowel sounds were sluggish. The rest of the systemic examination was normal. The point of care ultrasound was done, which revealed presence of interception. Since the child was hemodynamically stable, hydrostatic reduction was tried. However, due to failure of multiple attempts of hydrostatic reduction, the child was taken up for exploratory approach. The initial CBC showed neutrophilic leukocytes. Now I would request Dr. Geetanjali and Dr. Sneha to discuss regarding the intra findings and subsequently the histopathological examination findings of the tissues.
So we planned the child for exploration laboratory, and post intraoperatively we found that the child had ileocholic intussusception with a perforation at the base of the appendix. And the rest of the bowel was healthy. The plan was to dissect the 5 centimeter of the terminal ileum and 5 centimeter of colon distally and do ileocholic anastomosis. Rest of the bowel was inspected well, and there was no bladder discoloration or necrosis seen. Post-operatively, in the initial period, child was doing fine and child started on noodles on post-operative food. However, the child had persistent serious location from the wound, which was being managed conservatively with daily dressings. Good afternoon, everyone. So we received a segment of bowel, 6 centimeters in length, and we could appreciate that there was an interception at the level of appendix. There was an ileocholic interception, as we can appreciate here. And we can see this is the normal bowel mucosa. And this area, as described previously by ma'am, that there was a perforation. So we can see that there is a complete transmural infarction. And there are areas of serositis here. So for the sectioning at the high power, we can see that there are multiple fungal hyphae here in the serosal aspect. So various areas are sampled, and these are blood vessels which are filled with these fungal hyphae. We can appreciate that these are these fungal hyphae, parallel walled, broad, aseptate. A further high bar showing the same that these fungal hyphae are broad,
plate is a plate and shows branching. And these were vaso-invasive. They are getting these blood vessels as well. So final diagnosis of transmural ischemic infarct of the bowel with vaso-invasive mucormycosis was given.
Post-histopathological examination and diagnosis of invasive mucormycosis was made, and the child was started on liposomal amphotericin. But by day 11 of hospital stay, there was still the persistence of abdominal distension with bilious vomiting, and finally the child had developed burst abdomen, following which he was taken up for re-exploratory laboratory.
So we planned the child for secondary suturing initially as we were not suspecting any perforation. However, intraoperatively we found that there were two small pinpoint perforations, 170 centimeters from DJ and 30 centimeters from the previous anastomotic side. However, rest of the bowel was still healthy. There were no foci of necrosis, and thorough bowel wash was given for the minimal slough and the fecal contamination that we found. And section of that 5 centimeter segment of bowel was performed and end-to-end anastomosis was done.
So we can see that the child had fecal contamination and had developed E. coli sepsis with septic shock requiring inotropic support. And since the child was on liposomal amphotericin B, had developed life-threatening hypokalemias requiring multiple KCL correction during the due course. So by day 18, the child again deteriorated, developing generalized tonic-clonic seizure. Initial possibility considered was the dissemination of the mucormycosis, and also since the child had ongoing cytopenias, CNS bleed was still high on cards. And however, during the due course, the child had hypertensive record, and hence posterior reversible encephalopathy syndrome was also considered. And the CCT did reveal the changes which were consistent with the findings of PRES. And the child was started on anti-rise ICP measures along with the continued capital oil infusion and mechanical ventilation. The child totally had a HDO course of 2.5 months and then subsequently showed a clinical improvement and completed 12 weeks of antifungal therapy. Due to life-threatening hypokalemias, the liposomal amphotericin B was later switched on to IV posaconazole, which later was changed to oral posaconazole for discharge. So you can see that these were the various challenges which we had to overcome for stabilization of the child. Each of these could be life-threatening and very difficult to manage. And coming to case 2, Mr. H, a 2-year-old boy, a case of B lymphoblastic leukemia, who completed his post-induction chemotherapy, was on high-risk consolidation. He presented to casualty with complaints of abnormal body movements, and subsequently he had status epilepticus, was started on anti-rise ICP measures and appropriate antibiotics. Initial CCT did reveal presence of ring-enhancing lesion with surrounding abscess, and the initial possibilities considered was bacterial abscess, tuberculosis, and fungal abscess. The CT findings and all the imaging findings would be discussed subsequently. The burr-hole drainage of the abscess was done, and the extensive etiological workup was done. The KOH mount had revealed the presence of septate hyphae with folding, and the pus which was sent was positive for Aspergillus and Fusarium. And subsequently, the corresponding serum galactomannan was very high. It was 1.9. So this is the KOH mount. You can appreciate the presence of the septate hyphae. And subsequently, the child was started on IV liposomal amphotericin B, and like the previous case, had developed life-threatening hypokalemia, requiring the change of antifungal therapy to voriconazole. Voriconazole levels were serially monitored, and adequate levels were ensured during the due course. So, post these two interesting cases, let's come to case 3, one of the most common site of the fungal infection, which is the respiratory system. And this means a 6-year-old girl, a case of relapsed BLL. Note that in cases of relapsed BLL, we tend to start the patients on voriconazole prophylaxis. And the child was a case of high-risk febrile neutropenia. She presented to the pediatric emergency with lower respiratory tract infection. Initial chest X-ray was pretty normal. However, during the due course, the child had persistent respiratory distress requiring escalation of the respiratory support. So the initial workup was done, and CCT revealed the presence of the necrotizing pneumonia involving the right upper lobe. Again, the possibility given the background of immunosuppressive therapy and malignancy, the first possibility was the invasive fungal infection, which is mucormycosis, and still the bacterial pneumonia cannot be ruled out. The child was started on liposomal amphotericin B. However, there was no initial improvement, and the child still developed persistent H3 FNC requirement. Following which workup was done, and the KOH mount had revealed a accepted hyphae, and the culture was positive for Aspergillus teres. This is the KOH mount. You can clearly appreciate the accepted hyphae. And this is the culture showing the Aspergillus teres growth. And the child was continued on liposomal amphotericin B, and posaconazole was added to cover the Aspergillus teres. Subsequently, the child still developed the massive hemoptysis, and ball culture which was sent showed the presence of the Aspergillus teres, and hence nebulization amphotericin B was added. And the child currently is hemodynamically stable, had completed or 12 weeks antifungal therapy, and is doing well and is planned for discharge. Now I request the radiologist sir to discuss all the imaging findings of these cases. Thank you.
Good afternoon, everybody. I will be discussing the imaging finding of the cases. Case number 1, which presented with the symptoms of obstipation. The abdominal X-ray shows the dilated bowel loop, suggested of intestinal obstruction. The followed CECT chest plus abdomen shows the dilated small bowel loops with the feculent material within the dilated bowel loops, giving the fecal small bowel feces sign, suggestive of small bowel obstruction, with intraperitoneal air suggestive of pneumoperitoneum, along with the burst abdomen in the form of right anterior abdominal wall defect, and there is subsegmental collapse on the left side. The patient underwent CCT head followed by MRI in view of seizures, which showed a subcortical white matter edema in the right parietal region. On MRI, it shows 2-2 flare hyperintensity with the cortical thickening and diffusion restriction within the overlying cortex, suggestive of post-ictal edema. Case number 2, which presented with the history of seizures, shows 2 peripherally enhancing well-defined lesions suggestive of abscess with perilesional edema in the left frontal as well as in the left parieto-temporal region. The possible differentials were given as bacterial, tuberculosis, or fungal, and patient underwent Burn surgery with sample came out positive for fungal disease. On follow-up imaging, there is a near complete resolution of the left frontal abscess within a duration of 5 months, whereas there is a gradual decrease in the size of the left parieto-temporal abscess within a duration of 2 to 3 years, and present latest MRI showed a subcentimetric residual tiny foci of enhancement in the left parieto-temporal region. Case number 3, with presented with the symptoms of LRTI, the chest X-ray was done, which showed a new onset right upper lobe as well as upper zone and middle zone consolidation within a duration of 1 week, following which CECT chest was done, which shows the hypoenhancing area in the right upper lobe consolidation with intersecting strands within a large cavity surrounding the consolidation, suggesting the Bird's sign. Along with it, there are multifocal consolidations in the right middle lobe as well as lower lobe with the minimal right pleural effusion, with multiple parenchymal nodules in the bronchosvascular region with surrounding ground glass opacity. So pulmonary, the imaging features which favors mucormycosis over aspergillosis are Bird's side, more than 10 pulmonary nodules, pleural effusion, and concomitant sinusitis with development of the infection despite voriconazole prophylaxis. A follow-up imaging CTBA was done in view of the hemoptysis, and it shows retraction of the necrosed lung with centrally retracted neck infarcted lung with the in between there is air fills which it suggests air present sign. On bronchial CT bronchial angiogram shows the dilated tortuous right bronchial artery, whereas there is no evidence of invasion into the pulmonary vessels. So follow-up imaging was done with serial X-rays, and it shows near complete resolution of the right lobe consolidation with resolution of right sided diffusion with persistent air-filled lung cavity in the right upper and middle lobe. So these are the companion cases which shows the typical imaging signs, hypotension sign, crescent sign, and the nodule consolidation with GGO, which was seen in our case as well. These are airway invasive aspergillosis, which shows multiple central open nodules with surrounding ground glass opacity, signifying airway invasion. The reverse halo side, in which there is central GGO with the peripheral consolidation, and the bird nest sign, as we see in our case as well. And their complications of mucormycosis includes the lateral chest wall invasion, as well as vascular invasion leading to the pseudo aneurysm formation. Now I would like to hand over to Dr. Shriyani for further discussion.
So after seeing 3 different organ involvement by invasive fungal disease, I'll be discussing briefly about invasive fungal disease. So why are these more challenging? The symptoms generally tend to be more indolent when compared to the bacterial or viral infections. They have a huge potential for hematogenous dissemination. And in a setting of immunosuppression with disseminated IFD, it becomes very difficult to salvage these patients. And the timely diagnosis and treatment of IFD, as in our cases, improves the survival and also limits the morbidity. So when do we suspect an invasive fungal disease? So after 96 hours of broad spectrum antibiotic cover, if the patient is still neutropenic with mounting fevers, and we have made a reasonable attempt to exclude both bacterial and viral infections. And the common organisms which we deal with are the yeast like Candida, Cryptococcus, the mouths like Aspergillus mucor, or the dimorphic fungi. So this was an article which was recently published in 2025. It was a huge cohort of around 100,000 patients, which showed that incidence was around 3.4 to 10%. And it was significantly higher in our allogenic HSCT cohort, which was around 10%. The most common organism was the Aspergillus, which was around 45%, though which it was not statistically significant, but there was a shift towards Candida being more common after 2010. And when a subgroup analysis was done, in the chemotherapy cohort, Candida was still the leading cause of invasive fungal disease. But however, in allogenic HSCT patients, it was Aspergillus accounting for 67% of cases. So this is the rationale behind why we give a mold active prophylaxis in these patients. So what are the risk factors which make one susceptible for invasive fungal disease? There are certain malignancies like acute myeloid leukemia, the relapse setting, the high risk BALL, patients undergoing allogenic HSCT, patients with prolonged neutropenia which is lasting for more than 7 to 10 days, or those on high dose corticosteroids. And the routes of infection, the molds generally cause infection by inhalation via the sinuses or the lungs. And Candida species are associated with the catheter related bloodstream infections, associated with the PICC line, the central venous line, or the chemopoles. So in 2020, the EORTC, that is the European Organization for Research and Treatment of Cancer, has updated the definitions of IFD. We know we have 3 different IFD, like proven invasive fungal disease, the probable invasive fungal disease, and the possible invasive fungal disease. I'll be taking them one by one. So the possible invasive fungal disease, in a setting of immunosuppression, if a patient meets the host factors that are the conditions making him high risk for invasive fungal disease, and the clinical evidence, which are the imaging findings, without any mycological evidence, we say that it is a possible IFD. But on top of a host factor and a clinical factor, when we have a mycological evidence, like these are the mycological evidence, like for example, in the case of pulmonary aspergillosis, if we are able to isolate the aspergillus from the sputum or the ball, then we say the person is having a probable IFD. But if we isolate the aspergillus from the lung tissue itself, then it accounts for a proven IFD. For diagnosing aspergillosis, we also have other tools like galactomannan and the PCR, which I'll be discussing in my coming slides. So in a case of proven IFD, it is irrespective of the patient being immunocompromised or immunocompetent. That is, we do not have a host factor or a clinical evidence. We just need to isolate an organism by histological or culture of a specimen from a tissue which is taken from the site of the disease. So as in our first 2 cases, in the first case, we were able to isolate mucor from the gastrointestinal tissue. And in the second case, from the fungal abscess, we were able to grow Aspergillus species. So these 2 cases come under the proven IFD. So the various methods for diagnosis, it's a multi-pronged approach. It includes the direct microscopy, the fungal biomarkers, the molecular methods which are recently upcoming, and the radiological evidence. So for a direct microscopy, yeast we see as a budding yeast cells, and Aspergillus we see them as a septate hyphae, and based upon the arrangement of Conidia, we classify them into different species. And for mucor, we generally see them as a aseptate hyphae. So moving on to the fungal biomarkers. So galactomannan index, it is predominantly, this galactomannan is present in the fungal cell wall of Aspergillus, and it is released during the tissue invasion. And so in a patient with angio invasion or in a neutropenic setting, due to the poor immune response, we tend to have a higher galactomannan index values. So based on a meta-analysis, the most sensitive and specific cutoff for various fluids were given as follows: like single serum or BAL more than or equal to 1 is highly sensitive of around 85% and specificity was around 95%. However, in a setting of if the patient is already on a mold active prophylaxis, the sensitivity of this index decreases, and hence a blood screening on these patients is not required. However, in the ASCO 2023 febrile neutropenia guidelines, it is still a weak recommendation against the use of galactomannan because of the poor positive predictive value of 41%. And though it has a high negative predictive value, but it does not rule out the other non-Aspergillus models. So even the ITSA 2016 considers them as a good diagnostic markers, and a serial monitoring should be encouraged rather than a cross-sectional value. And these are some various conditions where we tend to have a higher galactomannan index. So moving on to beta-D-glucan. So beta-D-glucan is a component of cell wall, and the mucorale species produce very low amount of beta-D-glucan, and it has a very poor positive predictive value, and the sensitivity and specificity is also low. And even the molecular methods, they have a very poor positive predictive value and a low sensitivity specificity. Hence, the ECL 2020 guidelines or the ASCO 2023 guidelines are against the use of these two for the diagnosis of invasive fungal disease. So radiological features have already been discussed, but in a neutropenic pediatric population, most of the signs are generally non-specific. So moving on to the treatment includes not only the antifungal agents, but also the surgical removal whenever it is feasible and tackling the underlying predisposing factor for immunosuppression. So the common antifungals which we use are the amphotericin B, which is a polyene agent which acts by creating a pore inside the ergosterol, thereby causing the leakage of the membrane and causing a sidal effect. The triozoles, which act by inhibiting the ergosterol synthesis pathway, and the echinocandins, which act by inhibiting the beta-D-glucan synthesis. So these are the spectrum of the various antifungals. So fluconazole has yeast activity and a no mold activity. Itraconazole has predominantly yeast activity. Voriconazole has both yeast and mold activity, but it does not have any activity against the mucor species. And the side effect profile is very huge. And it also has various drug interactions with many chemotherapeutic agents and anti-epileptics. Hence, a therapeutic drug monitoring becomes essential by targeting the range of around 1 to 5 microgram per ml. Posaconazole is one of the oral broad-spectrum antifungal, which also includes the mucor cover. And isobuconazole was recently approved last year for the pediatric population, and it also has a broad-spectrum oral anti-mold activity. So caspofungin has a sidal effect for yeast activity, but however, it is a fungistatic for Aspergillus. And we all know that liposomal amphotericin B is one of the broad-spectrum antifungal which is available, and the doses vary depending upon if you are giving it as a prophylaxis or a targeted therapy to Aspergillus or mucor. So what are the challenges which we face while prescribing the antifungals? One is the availability, the affordability. Most of the newer antifungals are highly costly. The availability of therapeutic drug monitoring level, the various side effect profile, and in a setting of malignancy, when the child is already on various chemotherapeutic agents, the drug interactions become very important. So moving on to the treatment strategies, we basically have three major treatment strategies. When we have a patient with fever not responding to antibiotics and there is no evidence of any fungal disease, that is known as an empiric treatment. But once we have a galactomannan positivity or a CT chest finding suggestive of invasive fungal disease, then it is a preemptive strategy. And once when we are able to isolate the organism either via BAL or any other invasive diagnostic, we say that it is a specific treatment. So in our first case, we have seen the child had GI mucormycosis, and also third case we had a pulmonary mucormycosis. So this mucormycosis, it's a very lethal disease and is characterized by angioinvasion, tissue necrosis, and vascular thrombosis. And India, it contributes for a major chunk of the global burden. Around 66% of the global burden is by the Asia, and 92% of that Asia is contributed by our Indian population. So the most common cause is diabetes. However, the malignancy cohort, that the hematological diseases and the HSCT, they contribute around 20 to 21%. The most common form is the rhino-orbital cerebral form, but however, in malignancy, it is a pulmonary organ involvement, which we generally see. So it's a review of literature showing around 10,000 cases, in which only 149 cases were of GI mucormycosis, and the incidence was less than 1.5%, which was pretty rare. And these are the various methods which were already discussed for diagnosis. And one should remember beta D glucan or galactomannan are very less useful for diagnosing mucorales. So management after the introduction of antifungal therapy with surgical debridement, the mortality has significantly improved. And it was one interesting review that showed that when amphotericin B was used alone, there was mortality rate of around 31%. But however, when it was combined with an azole, either simultaneously or one after the other, there was significantly reduced mortality. However, and even there are some in vitro synergistic activities seen with the combination. But however, there are no randomized control trials or head-to-head, prospective trials, which showed the effect of this combination. Hence, the ECL 2020 pediatric guidelines still recommend that there is insufficient evidence to support this combination and should be used on a case-to-case basis. And the surgical resection of the necrotic tissue is highly important in a setting of mucormycosis. In certain cases like GI mucor, the renal mucor, or the rhino-orbital cerebral form, because if surgical debridement is not done, there is a high mortality of reaching up to 100%. So last slide about GI mucormycosis. It has a very non-specific presentation with abdominal pain, distension, and imaging findings are also very non-specific. Hence, there is a delay in diagnosing these patients, and mostly they are found intraoperatively or postmortem and has a high mortality rate of up to 85%. And the treatment is generally in the lines of any other mucormycosis with liposomal ampho starting at a 5 mg per kg per day. The second line being posaconazole or the isavuconazole or the combination therapy based on case-to-case basis. So my take-home messages are a very high suspicion of invasive fungal disease should be considered because of the indolent nature. A multidisciplinary approach is essential for the effective management. Prompt antifungal therapy and timely surgical debridement is the key. The preemptive strategy should be encouraged rather than empirical treatment. And combination therapy should be used rationally on a case-to-case basis. And there are no guidelines for duration of therapy. However, they are guided by the resolution of the clinical, radiological, or the underlying immunosuppression. Thank you to all the presenters. So why we chose these three cases was that it is actually getting very challenging, and what we have, the changing profile is that we are getting a combination of fungal infections. Earlier it was one species, now we are getting a combination of species, and also there is a tendency to use a combination of antifungal, the rational use of antifungal therapy as well. So and of course these were unusual sites where surgical debridement, which is one of the most important modality told to manage mucormycosis, we could not use. It was not very feasible when it came to GI mucormycosis. So we have Dr. Gagandeep and Dr. Vishesh, if they would want to say something how challenging it was, because this was a GI mucor which we identified for the first time, and which without, I think, surgical debridement or intervention carries a 100% mortality.
So for the first time, we never expected the patient to have a mucormycosis because he came with a intersection to us. And by protocol, if we hydrostatin reduction doesn't work, then we go and operate. And we had a perforation, so definitely we had to do a resection and anastomosis for this. And that was the finding. It was an incidental finding. But what we realized, it has repercussions in the postoperative period. Because if you see the history, the child recovered within 4 days. We started orals in 4 days. But he had this ascites before the report came to us, which we were not able to explain, that why the patient is able to accept oral treatment but had ascites. So probably because of that fungal and mucormycosis, we had this thing. Another thing is, although it's very difficult to take a decision in these cases because whether to do anastomosis or not, because healing is impaired in these patients. But the problem is, if you create a stoma and they are known to have swift lesions, they can have a perforation after a couple of weeks again, because if they are invasive, they block the arteries and it causes necrosis. So how many stoma do you create? So it's a very technical challenge for you to decide whether to create a stoma or do an anastomosis. And the recovery is very difficult, and medical management is very important, which was done.
Exactly. So Dr. Gagandeep, would you want to just comment that how difficult is it to identify the species? Because the choice of antifungal is really important and it all depends on the species that is isolated and how long does it take to identify the species?
So the species, if you look at the treatment, it's not dependent on the species. So most of the species would respond well to a liposomal amphotericin, although there are anecdotal reports where even a Rhizopus rhizus or genus like Apophytomyces might not respond to liposomal amphotericin, but nothing is conclusive. Mostly the first line is liposomal amphotericin. As far as species identification is concerned, it's totally dependent upon the skill of the mycologist. So these can be done even phenotypically, although we do sequencing very often these days, but even phenotypically these can be identified. So Rhizopus mucor, Rhizomucor, these are easily cultivable also. Genera like Epiphytomyces, it's not easy to cultivate as well. Another thing I'd like to point out is that most of the time the diagnosis is based on direct microscopy. And if you see typical morphology of broad aseptate hyphae with 90-degree angle branching and other features, and even in the best of hands, the culture is going to be positive maybe just in 50% of the cases. So our reliance on culture should be low. It should be on direct microscopy, and as it is going to take 3 to 4 days at least additional for the culture to come. And plus, like one of the cases we had, Aspergillus and mucor. So there we've seen that if you have septate and aseptate hyphae, invariably the septate ones grow and the aseptate won't grow. Probably there is inhibition by the Aspergillus on the growth of the mucorium. So there the recovery becomes maybe 20% in culture.
Any comments from or questions from the audience?
Madam, I was just, since you have been treating these kind of cases, so what is our incidence of fungal infection in our cases? And one of the review articles was shown that in other cases, somewhere it was like mucormycosis was more common, and after transplant it was like aspergillus the other way.
Candida was the most common in the chemotherapeutic cohort. However, in the setting of allergenic HSCT, it was Aspergillus, which was around 67%. However, the incidence of mucor was less than 5%, 4.4% in the whole cohort. So, but after 2010, the Candida species are becoming more common, but it is not statistically significant.
So, even our data reciprocate the same?
So, we also see mold. It also depends upon the local epidemiology, sir. It varies from the institute to institute and the country also. We generally tend to see more of molds in our setting. So, we generally start on a voriconazole prophylaxis, which is a mold active rather than a anti-candidal prophylaxis.
Exactly.
So, yeah, exactly. So, in our the prophylaxis that we use for all our patients is an anti-mold and not against Candida. We generally start with voriconazole because you have to see the epidemiological profile of your center. So it has to be individualized. So we start as per convention with voriconazole, and then again the drug monitoring, again those considerations come up when we have to have a therapeutic intent to treat them. So again that becomes again a hindrance when the intent changes from a prophylactic to a therapeutic intent. So
one is that yeasts are mostly healthcare associated. So it's going to be your patient on a central line or invasive devices. And it's going to be, or your practices really reflect on candidemia. If you have very high incidence of candidemia, it means that the practices are not appropriate. Number two is that most of the molds are going to have good yeast activity as well. So if your patient is on a voriconazole, it's going to take care of the entire spectrum of yeasts. So taking care of the yeasts.
Exactly. So that's why generally what has happened is that in the recent times we've identified mucor. So voriconazole will not protect our patients from mucor. So that is the whole concern that we need to identify. That was the reason why species identification becomes important.